Thank you to Prof. Siebenrock. It's a great honour to be asked to share my experience with this here today. And I'd like to thank my mentor, Jit Balakumar, who's also present, as well as the countless surgeons from Switzerland for my fellowship here. So I disclose actually that I do receive consulting fees for development of this product, and I am aware of that. So what's the goal of a total hip replacement? We spoke with Professor Haddad spoke yesterday about our results, and we need to think about the patient in terms of what we're trying to achieve. So we want to eliminate pain, we want to achieve a stable joint, we want an impingement-free range of motion, we want to restore leg length, achieve a normal gait with well-fixed implant. And if we do that, we'll have a happy patient and we'll have a happy surgeon. It seems simple, except that it's not. And even though total hip replacement is the operation of the century, multiple studies show that up to 15% of patients are dissatisfied with the result. We saw from Professor Haddad's results in the NHS yesterday that in the UK they're unhappy. In Australia our results are slightly better, we have 89% satisfaction, but that's still 11% of patients who are dissatisfied. And this is a moving target. In the 1970s, patients were happy to sleep without pain, walk with a stick, spent 10 days in hospital, and were happy if the hip lasted 10 years. Whereas now they want to play golf and tennis, they want to do yoga and skiing, they want to be out of hospital within 24 hours, and they want the hip to last the rest of their life. This is one of my patients here on the right. I struggle to think what she's going to be doing with that hip over the next few years. When we think about patient expectations, we've got to consider both failure and performance. And as surgeons, we often focus on the failure side. That's revision surgery for things like dislocation, leg length discrepancy, implant loosening, fracture or component malposition. But patients care much more about the other side of the equation, which is how satisfied they are. What's their improvement in pain? How do their muscles function? What's their range of motion? And do they get back to the activity or sport that they want to participate in? And we as surgeons probably need to focus less on registry results and more on how we achieve a satisfied patient. Many patients will be dissatisfied with the outcome of their total hip replacement despite it not warranting a revision. Consider something like psoas pain with a slightly overhanging acetabular component, thigh pain from a well-fixed stem invarus that's loading the lateral cortex, trochanteric pain from too much offset, or just a small leg length discrepancy which you wouldn't think warrants a revision. Understanding the hip in 3 dimensions and the patient's demands with the use of a 3D planning software will help solve this problem. So if we look back at the past, or what many people are still doing now, it's the gold standard up until now, is 2D templating. It helps us reproduce the anatomy, helps us restore leg length and offset, but it's less accurate if there's a deformity like fixed external rotation, and we can't quantify anteversion. We really rely on the radiographer and how they position the patient to understand that. And it certainly doesn't give us any information about functional alignment. When we look at what is available now, we have 3D templating, which helps me understand, the third dimension of the hip. That's the sagittal balance, so pelvic tilt and spinopelvic kinematics, as well as axial alignment. What's their torsion like? And much of the pathology, as we've seen over the last few days, much of the pathology results from these issues. So shouldn't we be considering them as part of our reconstruction? Here's an example. It's a 48-year-old female who enjoys yoga and walking. She had a rapid progression of left hip OA from dysplasia. She presents with lower back pain, and I get the impression that she has some anterior pelvic tilt. She had a hip replacement done with 2D templating, and it was a dysplastic hip, and that maybe they didn't identify the fact that the anterior wall was deficient, and they've antevoted their cup a little bit too much. But leg length and offset appear well restored. Unfortunately, she pivots in the kitchen at 6 weeks post-surgery and dislocates, and at a year after her operation, she has persistent lower back pain when she presents, her hip feels insecure, and there's head migration with polywear. So even with modern, highly cross-linked polyethylene, malalignment in this situation can still result in a catastrophic failure. What was interesting was that her standing lateral image showed facet joint disease in the lumbar spine and residual anterior tilt in that standing position. This is a pelvis that has been driven to tilt posteriorly, but it can't because the hip is unstable. So she had a minor revision. That's a ceramic on ceramic monoblock, not a metal on metal, don't be afraid. That allowed the pelvis to posteriorly tilt, and her lower back pain resolved and her hip was stable. How could this have been avoided? Well, if we recognise the adaptive anterior tilt, which is often present before surgery, and compensate for that by not over-antiverting the cup, then we'll improve anterior coverage and reduce posterior impingement. So this is the planning interface that we use, and in this situation now I'm using it to interpret the failure of this implant. And you can see that when I model the position, she's in 48-25, which is not what we aim for, but it's also not terrible. You wouldn't expect a catastrophic failure. What was interesting was that if I look at her in the standing position, that turns into 57-36. And when we use the modelling part of the planner, that we can see that with just 7 degrees of extension and 6 degrees of external rotation, she has posterior impingement with a contracure lesion to the anterior rim. So in terms of avoiding this, there's three components to it. Number one is functional imaging, so we understand the patient's position in space and how they move. We need 3D templating, and I use the advanced MyHip planner, and then some sort of intraoperative verification to achieve the plan that you've set out to. So back in 2017, when this journey started for me, we had a CT-based planner which was good for sizing and implant choice and position, and leg length and offset, but it lacked correlation with functional imaging and gave me no frame of reference. But from 2019, the planner has incorporated functional imaging. If we go back to the start of the hip spine movement, Aaron Buckland at the Hospital for Joint Disease published on or identified that dislocation was more common in patients with spinal fusion. Subsequent to that, Jonathan Viktorczyk and the rest of the group at HSS have published a classification system of the hip-spine relationship, which assesses spinal mobility, deformity, and alignment. They use their standing functional pelvic plane as the reference, and then they developed an algorithm for optimising acetabular component position. And they recommend increasing anteversion to compensate for the risk of posterior dislocation and flexion. But they pay less attention to the risk of posterior impingement. Why should we use standing images? Well, the hip is loaded in extension. Pelvic tilt changes, as we know, between supine and standing in most people, on average 3 degrees, but over 7 degrees in 15% of patients. The changes in the pelvic tilt, as we know, alter acetabular inclination and version. So at a minimum, I'd recommend that you use a standing AP pelvis X-ray, but ideally a standing AP and lateral EOS. And that's because it gives us a better understanding of the lumbar spine and how it might change post-operatively. The sitting position is more useful for instability. Well, instability and impingement occur in flexion, and so we get more information from the sitting images. It tells us about how the pelvis moves to accommodate hip flexion and provides information for our planner in terms of modelling that flexion range and impingement. So this is what provides us with information on the third dimension, and we must consider it, because if we don't, then we can't optimise the position of the components in space to maximise function. But the big part of this, which I don't think people pay attention to, is that they don't realise that this functional imaging is just a snapshot in time. A hip on the left, which was stiff and painful with osteoarthritis before surgery, can suddenly change after surgery to move dramatically more. He's now increasing his sacral slope by over 20 degrees, and that cup's facing the floor, and that's taking this patient from a low risk to a high risk patient. So you have to plan for a worst case scenario. And we've also got to consider what happens over time, and our results talked about this, or asked a question about this a couple of days ago. Disc and facet joint disease causes back pain. The lumbar lordosis flattens as we age to relieve that pain. You get a compensatory increase in thoracic kyphosis, and the pelvis tilts posteriorly. This posterior pelvic tilt increases acetabular anteversion, it reduces anterior coverage, and you almost get a secondary dysplasia of the anterior rim. You get increased posterior wall coverage, and obviously that increases the risk of posterior impingement. And if you're thinking about how this happens, the patient who's hyperlordotic early in life is the one that will have a greater change. And the younger the patient is when you're considering doing a hip replacement on them, the more you have to consider the potential for future change. This is an example of an older patient who came to see me. You can see that they've got lumbar spine OA, but it looks like a fairly benign hip. She gets a hip replacement by another surgeon, and she comes to me at about 6 months post-surgery, walking on a frame. She can't stand up straight. This is her standing x-ray, which was done pre-surgery. You can see that she's in an outlet position there. And her lateral image shows that she's got lumbar spine OA with 16 degrees of posterior tilt. Now, if we put the hip back where it was, then she'll get anterior rim loading, posterior impingement, instability, or all of the above. And you look at her standing x-ray when she came to see me, you can see why this hip needed a revision. Here's a similar one. Now, this one's a little bit more subtle. This patient had right hip OA with lumbar spine OA and back pain. She had a hip replacement by one of my colleagues several years ago, and it didn't fail. They weren't particularly happy, but there was no major issue. She came to me about 5 years later with left hip pain and deteriorating lower back pain. That's a real clue to these problems. And you'd think that it's a fairly straightforward hip replacement. On the lateral image, she has a neutral functional pelvic plane, so fairly upright, but she has a low-grade spondylolisthesis, and she's got an anterior translation of her SVA. You can see her SVA is in front of the centre of the sacrum. So this is a pelvis which I think is going to tilt posteriorly acutely post-operatively, so I must avoid excessive anteversion. But the kicker is that she tilts anteriorly in flexion, which means there's a battle between a pelvis which extends in extension and flexes in flexion, and so she's a high risk of dislocation as well. So we don't want to over-retrovert. So I'm going to take you quickly through how this system that we've got works, and a brief plan for this patient and how we would think about it. So you start by focusing on the obliquity of the pelvis. We then log the images. You can either input the images directly, or you can identify the images on the x-rays which you've imported. And you go through all the landmarks to identify lumbar lordosis and sacral slope and pelvic incidence. And then you can look at the positions in flexion as well as the femur shaft in standing and sitting, which allow you to model that range of motion. It'll then interpret whether there's a deformity and whether or not the spine is stiff. We then move to the planning phase, or the landmark phase, and you can see at the top here, we've got pelvic tilt. I'm tilting her posteriorly because I think she's going to go backwards. And that's the position which I think she's roughly like to end up in. The plan will then use AI to assess all of the landmarks, including femoral torsion and intra-articular leg length and longer leg length. And we then move on to the planning phase, and you can see that the initial plan showed the cup in an anteverted position to model the local landmarks. So I'm going to say I'm going to retrovert that cup back to where I wanted at 40-20 in the standing position. But the cup's too big now, so I'm going to make the cup a little bit smaller. I don't want a psoas impingement, so I'm going to medialise it a little bit. And now I'm happy, but I see there's a bone overhang posteriorly, and I'm going to want to resect that. And you can see in the CT image that that's all labral ossification rather than true acetabular rim. Moving on to the femur, you get a rough plan to start with, and I do most of the planning here in the axial because it gives you so much information about where you're going to get bony contact. And I bring the femur down into the right position. You can change the size, and it will estimate the leg length and offset change that you're going to achieve. You can look at whether or not there's increased bone density that might cause a hang-up of your prosthesis, and you can change between prostheses so you can work out which implant is going to be the best for that patient's morphology. You know, in this one, you think, oh, well, maybe I need to use a short cemented stem, but in reality, I was pretty happy with the first one, so I'll go back to that one. And then it's nice to then do an assessment of the leg length discrepancy at a head size to make sure that you've got that reconstruction right. And then I can look at whether or not I've restored the hip centre relative to the native femoral head, because I obviously don't want to increase anteversion. You can see there. And I can also remove the implant and the native femoral head to then look at the entry point that I'm going to use, because that's probably the thing which will determine most where the stem ends up when I broach. And then we get to the assessment phase. You can see here that we have restored leg length and offset well, but I've got this anterior offset of minus 5 millimetres, and that's because in the extended position, when I ream into that acetabulum to medialise to get the anterior rim underneath the native bone, it's actually posteriorising the hip centre as well, and you can see how the femur moves backwards when I do the reconstruction. And I'll accept that in this patient, but it probably means that she's at a higher risk of ischiofemoral or other posterior impingement. The system then has a impingement detection module, which allows me to look at the extremes of range of movement in standing and sitting. It also has other functional movements. We're not yet at the point where we can put in the fact that they're a golfer or a tennis player, but that will come with time. And here we can see that if I go into extension, external rotation, that she impinges on the posterior rim, but that bone is going to be removed, and she's not getting any posterior cup impingement. So at just 8 weeks post-surgery, the pelvis is tilted backwards as we expected. The patient's delighted with the hip and the back pain is resolved. And you can see now how unnerving you would be about the right hip if that was yours. So what are the benefits preoperatively for this 3D planning? Well, it allows me to perform a virtual surgery on the patient ahead of time. This helps me better understand the pathoanatomy and makes me better prepared as a surgeon for the surgery. It guides implant choice in terms of type, size, and the fixation mode that I use, and it allows me to better counsel the patient in terms of leg length. Perhaps she might have a psoas problem or other challenges. And it's good for standard cases, and it's even better for your complex cases. Intraoperatively, it dramatically changes your workflow in terms of time. It reduces the inventory you might need from an instrument and an implant perspective, and it allows accurate execution of your surgery. And I use fluoroscopy, though you could equally use navigation or augmented reality. There's no trialing necessary really. If you've got your components in the right position, the reconstruction will be good, and it helps me avoid intraoperative complications like fracture because you're not chasing another size to get press. Post-operatively, better sizing means we should have a reduced risk of loosening, and a more accurate reconstruction maximises abductor function and range of movement, should mean a happier patient. Hopefully the improved cup position, implant position will mean less chance of instability or psoas problems. As an education tool for residents, this is an outstanding device, and for me as a surgeon, it provides continual learning and feedback. What does the future hold? AI integration is the next step. They're going to automatise the planning system and optimisation. There'll be continued development of activity and patient-specific impingement modelling, so we'll be able to do activity-based modelling. And there'll be further integration with augmented reality, navigation and verification platforms. Hopefully that should give us a better understanding of the spinopelvic alignment and movement, and the way it will help with further development. And I'll finish by saying you won't be replaced by artificial intelligence, just by a surgeon who's using it. Thank you.